Dear Chairman, dear ladies and gentlemen, first of all, I would like to thank you for the kind invitation and for the chance to report on the European Task Force on ONJ and our 2019 document. The European Task Force on Medication-Related Osteonecrosis of the Jaw is an international group of experts for medication-related osteonecrosis of the jaw from a lot of European countries, especially Italy, Germany, Great Britain, Switzerland, the Scandinavian countries, Denmark, Norway, Sweden, and also from Greece. And we had an international conference and workshops in 2018 and 19 in Copenhagen, where we not only had a conference, but also tried to identify some of the problems, some of the challenges, and some of the controversies of the current literature, and especially of the current guidelines. And as we have identified several problems in these international consensus statements and guidelines, one of our main aims is to try to reach a European consensus statement on the pathogenesis, but also especially on the prevention, imaging, and treatment of medication-related osteonecrosis of the jaw, which should give guidance for clinicians, for dentists, for oral surgeons, for maxillofacial surgeons, but also for our colleagues from the osteology and oncology departments. Well, what are the problems? As you all know, the most widely accepted definition of medication-related osteonecrosis of the jaw comes from the American Association of Oral and Maxillofacial Surgeons, was firstly defined in 2007 and 2009, and the latest update is from 2014, and here I have marked in red the changes that have been included in 2014. So we define medication-related osteonecrosis of the jaw is defined as exposed necrotic bone or bone that can be probed for more than 8 weeks under an ongoing or previous intake of anti-resorptive medications like bisphosphonates, especially nitrogen-containing bisphosphonates and denosumab, or anti-angiogenic drugs with no irradiation of the head and neck area and no obvious metastases. Now, if we have a look at the staging of the disease, back in 2007, 3 stages were defined. Stage 1, which means bone exposure without signs of infection, so asymptomatic bone exposure. Stage 2, meaning bone exposure with signs of infection, so symptomatic bone exposure. And stage 3, the stage of complication. Complications like pathological fracture of the mandible, extraoral fistula formation, and or involvement of the maxillary sinus. And starting from 2009, it was realized that there are cases of osteonecrosis of the jaw that are not going along with bone exposure. So stage 0 was introduced, which means no bone exposure, but non-specific clinical and or radiological findings suspected for medication-related osteonecrosis of the jaw. And this is also the stage where we have several problems with. All in all, One of the main problems is that our definition of medication-related osteonecrosis clearly says that bone exposure or bone that can be probed through a fistula is required for the definition of medication-related osteonecrosis of the jaw. However, for stage 0, bone exposure is not present. So that means that stage 0 is obviously not included in the definition, but it is included in the staging of the disease, which is a problem. And we also have the problem that in the staging of the disease, especially between stage 1 and stage 2, there is no influence of the extent of the lesion, of the localization of the lesion. So for example, you could have bone exposure in a whole quadrant. It would refer to stage 1 if you have no signs of infection. But you could have a very small lesion in a single alveolus, but if you have signs of infection, it would refer to stage 2. And that is problematic. And it is also problematic that basically you can switch between stage 2 and stage 1 simply with the prescription of antibiotics. So if you have a stage 2 lesion and the patient is taking in antibiotic drugs, usually the signs of infection will vanish and the staging might change to stage 1 again. So that is something which is very unusual for a classification system of a disease, that simply with the prescription of antibiotics you could change the staging. And there is another problem. The staging is not clear and concise. Just to give you an example, if you have a lesion of medication-related osteonecrosis of the jaw in the maxilla without bone exposure, but with signs of infection and signs of maxillary sinusitis, it could refer to stage 0 because you have no bone exposure. But at the same time, it could refer to stage 2 because you have signs of infection. And it could also refer to stage 3 because you have an involvement of the maxillary sinus. So that is very problematic. And another thing that is problematic in the definition of the disease is the inclusion of 8 weeks delay. So basically we have to wait. If we really stick to the definition, we would have to wait for 8 weeks to clearly define MRONJ. And that will also delay our treatment. And it is also questionable where the 8 weeks come from. Why is it 8 weeks? Why is it not 4 weeks or 12 weeks? And why do we need to wait anyway if we clearly see the signs of medication-related osteonecrosis of the jaw? So a lot of the problems are already in the definition and staging of the disease. So the key statements regarding definition and staging that we as a group came up with is that the current definition of medication-related osteonecrosis of the jaw does clearly not identify all patients with medication-related osteonecrosis of the jaw. And the description of stage 0 is especially controversial and also difficult to interpret. And stage 0 is certainly a diagnostic challenge, and there is a lot of other dental and non-dental diseases that could refer, that could be diagnosed. Also, the 8-week criterion may delay diagnosis and consequently treatment. And also the role of imaging needs to be clearly defined. Is it necessary for the diagnosis, for the staging, for the treatment planning? And we can clearly state that the present classification system does not adequately reflect the disease extension and severity. And it might therefore be very problematic to base treatment decisions on this kind of staging. Now, regarding imaging, there is a question whether we need 2D imaging, 3D imaging. Certainly our standard is the use of panoramic radiographs, and the typical clinical findings that you can see is persisting alveolus, persisting extraction sockets, but also all signs of infection, sequestration, and also a mixed pattern of radiolucent and radioopaque patterns. In some cases, you might need 3D imaging like cone beam CT or CT scans, especially to identify involvement of the maxillary sinus, but also to identify sequestrum formations and maybe the extent of disease, but also in extended lesions in the mandible or to identify pathological fractures. It might be useful. Now, another problem is tooth extractions in patients with anti-resorptive drugs. So regarding literature, we know that the majority of MRONJ cases or manifestations, we should rather say, takes place after tooth extractions. So in a lot of publications, tooth extractions are considered to be a local risk factor. And sometimes they are even believed to be a triggering event or a cause of MRONJ. So there are some recommendations to avoid tooth extractions in patients with anti-resorptive drugs, which we do not think is correct. But at least there is considerable uncertainty among oral and maxillofacial surgeons. Now, just to give you a brief overview about the study that we performed in 72 patients with 216 extractions. And basically what we did was an antibiotic prophylaxis, a smoothing of sharp bony edges, and a plastic wound closure after the extraction. And basically we had very little problems. And there was a slight tendency towards delayed mucosal healing and delayed remodeling of the extraction sockets, which is not surprising. But the most interesting finding was that at the time of extraction, we performed biopsies due to suspicious lesions of the bone. And in 20 out of the 29 cases, we already at the time at extraction, we found signs of osteomyelitis and partly or completely devitalized bone. But we saw healing. Now, that brings up the question whether really the extraction is the cause of the necrosis, or rather what we think, and I also think which has been more or less proven in the past 10 years, that the infection is the main cause of development of medication-related osteonecrosis of the jaw. And so we can nowadays clearly state that tooth extractions do not automatically translate into an increased risk of medication-related osteonecrosis of the jaw. And the reported high risk of MRONJ after tooth extraction might be related rather to the underlying dental infection and or maybe inadequate treatment of patients with anti-resorptive drugs. But we are quite sure that tooth extractions can safely be performed with the preventive measures, meaning antibiotic prophylaxis, smoothing of sharp bony edges, and plastic wound closure. And actually, if the intention is a removal of infection, tooth extractions might rather lower the risk for the development of medication-related osteonecrosis. But it's certainly a point of discussion. And another thing where we have controversial statements is on the kind of treatment, surgical or non-surgical treatment. And initially there were a lot of recommendations for non-surgical treatment, meaning long-term antibiotic treatment, rinsing of the lesions, and oftentimes also stop of the anti-resorptive drug. But you can see that especially in the oncological setting, there are hardly lesions that completely resolve and heal under non-surgical treatment. Whereas during and after surgical treatment, which means antibiotic treatment, removal of the necrotic bone, and plastic wound closure, we can see that the healing rates are much, much higher, way higher than for the non-surgical treatment. And that is quite consistent for different groups throughout Europe and throughout the world. So another problem that we see in the treatment recommendations was that initially it was recommended to perform non-surgical treatment for stage 0 to 2. Now the recommendations have changed, and nowadays it is recommended to perform non-surgical treatment for stage 0 and 1 and surgical treatment for stage 2 and 3. But our own experience is that surgical treatment might be appropriate for very early lesions as well, especially as we have no infection and as we have very good healing rates. And just to give you a brief idea about our approach, which is usually fluorescence-guided bone resection, but that is maybe something special during the removal of the necrosis. But anyway, the most important pillars of treatment are antibiotic treatment, complete removal of the necrotic bone, smoothing of sharp bony edges, and also plastic wound closure. And in all of the big studies, we have healing rates between 80 and 90, sometimes even exceeding 90%. So we recommend early surgical treatment of the lesion with the intention of healing and mucosal healing of the lesions. So the key statements for management and treatment of the lesion is that at the moment we have no accurate staging system. So it is very problematic and potentially misleading to use the staging system to inform treatment recommendations. I think that is quite clear. And we also recommend to use the wording surgical and non-surgical treatment rather than conservative treatment, because conservative treatment somehow implies that it would be less invasive, and which is not always the case, because usually you don't get to healing, and therefore at the end of the day the lesion might be much bigger. And it is quite clear that surgical treatment is superior to non-surgical treatment if the intention of treatment is mucosal healing. But if the aim of treatment is reduction of symptoms, so pain, non-surgical treatment might be appropriate, especially in frail elderly patients or in end-of-life settings. But all in all, early surgical intervention on localized disease may prevent progression and the need for extensive surgery. So, having said all that, I would like to thank you for your time and attention, and I'm open for your questions. And I hope that we will be able to finish our treatment recommendations or consensus statement in the near future. So thank you very much.